Good morning or afternoon to our participants, depending on where you're joining us from across the country. And thank you for joining the Pan-Canadian Change Management Network's Change Management Framework in Action, Stories from Across the Country, Part 1. This is our fifth webinar in the Pan-Canadian Change Management Network Change Management Webinar Series. I'm going to get a few housekeeping items out of the way, starting with the notice that this webinar is being recorded and will be posted on the Infoway website. All participant lines are muted throughout, so you will need to use the Q&A feature if you wish to ask a question. You may ask questions throughout the presentation, and we will address them at the end of the presentations. We also have a disclaimer that I'll give you a few moments to read on your own. My name is Taylor-Hughes, a member of the Clinical Adoption Team at Canada Health Infoway, and also the Chair of the Pan-Canadian Change Management Network. We are pleased to have two groups of presenters joining us today. Krista Belenko, a Change and Evaluation Specialist from Ontario and the Atlantic regions, will introduce Melissa Chang and Diana Benjamin of the Connecting Greater Toronto Area Project and will share their experiences in governance around governance and leadership and communications. Ann Baldwin, a Change and Evaluation Specialist in the Midwest and West regions, will introduce Carl Mallory of the British Columbia First Nations Panorama Implementation Project, who will speak about his stakeholder engagement process. Today's webinar will focus on defining three elements of the National Change Management Framework: governance and leadership, stakeholder engagement, and communications. You will also hear stories from project teams from Ontario and British Columbia on how they leverage these change management elements successfully. Today's webinar will include a brief introduction of Canada Health Infoway, and then we will move directly to the presentations on the specified change management framework elements. After the presentation, we will have up to 15 minutes for questions. The webinar will then close at the top of the hour. To ask questions, please use the Q&A panel at the top of your WebEx screen by clicking on the drop-down arrow, selecting Q&A, and sending your questions to all panelists. The question and answer period will begin after all speakers have finished their presentations. Canada Health Infoway, sometimes referred to as Infoway, is a federally funded, not-for-profit organization created in 2001 with a mission to foster and accelerate the development and adoption across Canada of digital health information systems using compatible standards and communications by building on existing initiatives and through collaborative relationships. The Pan-Canadian Change Management Network, supported by Canada Health Infoway's Clinical Adoption Team, is a grassroots collaborative of change leader enthusiasts from across the country sharing best practices and ideas since November 2009. The network facilitates a national community of practice for change management leaders involved in the implementation of digital health solutions, providing an environment for discussion, networking, and knowledge sharing. It was founded to share experiences and identify common goals that address ongoing change management-related issues and concerns within the digital health space across the provinces and territories. The Pan-Canadian Change Management Network also has working groups that are formed on an as-needed basis to work on deliverables of the Pan-Canadian Change Management Network and provide national expertise, insights, and input to shape change management strategies and outputs to accelerate adoption and benefits realization of digital health solutions. The Pan-Canadian Change Management Network has developed an integrated framework for describing change management activities within the context of digital health projects that consists of 6 core change management elements. The core elements of the framework are made up of governance and leadership, stakeholder engagement, communications, workflow analysis and integration, training and education, and monitoring and evaluation. More detailed information for each of these elements can be found within our online Pan-Canadian Change Management Network community via Infoway's corporate website, and you'll hear more about this when we cover resources at the end of the webinar. Having a national change management framework helps to proactively focus attention on these core and vital activities, aiming to minimize negative consequences. Thoughtful contemplation of these undertakings, both in planning and in execution, proactively considers users of digital health solutions and presents communication opportunities. It also supports the integration of technology into practice and overall supports people and their organizations as they transition from their current state to the newly desired end state. This is the goal of the National Change Management Framework. I will now turn it over to Krista Belenko to open the session with cGTA.
Thanks, Karen. Good afternoon to all. In my role as a change specialist and project manager, I'm very fortunate to work with many great project teams from across Ontario and the Atlantic region. Today, I'm happy to introduce you all to one of them, the cGTA team. But before I do that, I'd like to quickly review two of the framework areas that they'll be covering today: governance and leadership and communication. The first area is governance and leadership. It refers to the mechanisms used to guide, steer, or regulate the course of a project. This section includes considerations for how stakeholders can affect priorities and progress, what change management activities are planned for in a project, links to existing clinical governance structures or working groups, and anticipating workflow or scope of practice impacts. Finally, as many of us have heard from ProSci's benchmarking reports over the years, the #1 factor in change management and adoption success is active and visible leadership. Infoway encourages all project teams to work closely with e-health stakeholders to establish programs with clear governance structures and accountability frameworks. The next section is communications. Communications refers to the process of providing stakeholders with what they need to know to prompt appropriate responses and action. In the planning for communications, it's very important to leverage the stakeholder analysis work completed and tailor approaches for each of the various stakeholder groups. Communications planning also includes establishing key messages by stakeholder group, determining the frequency and format of communication mediums, and assigning responsible resources. Finally, continuous monitoring is important to ensure that the intended results are being achieved, and if not, allow for adjustments to be made. It's now my great pleasure to introduce you to the cGTA team members. Melissa Chang is the stakeholder engagement and communications lead for the program. And next is Diana Benjamin, who is the adoption lead. Thanks again for joining us today, and over to you, Melissa.
Thanks, Karen. Thanks, Krista. Thanks, everyone, for attending today, and thanks very much to Infoway for including us. This is the first time we've participated in a conference like this. So we're very much looking forward to not only sharing our experiences, but learning from the other presentations and hearing what kinds of questions are of interest across the country. Today, what we're going to be focusing on is we're really going to try and focus just on our clinical work. We've been asked to focus on governance and leadership as well as communications, but we'll do that in the context of clinical stakeholders. But a lot of what we've done can be extrapolated and applied to a number of the other stakeholder groups that we're working on. So we're happy to take questions on that as well at the end. So also wanted to highlight for you that, of course, there's a lot of work that goes into programs like this. What we'll be doing today is just providing you with some of the highlights that we've seen be effective, but also just so that you all know, it's not just, don't just take our word for it, but we've gone through a number of lessons learned as well as ongoing feedback from our various stakeholder groups. And so these are really highlights of what has been validated for us as either having been unique for our program or that has really helped when we're thinking about governance and leadership and comms. So with that, let's just get started on this. I'm not sure how many of you would have heard of Connecting GTA. So just as way of background to set the context, the Connecting GTA program is the first of 3 regional electronic health records that are being delivered in Ontario. We work specifically with Central Ontario. So where the GTA comes in is we're really the surrounding area of the Greater Toronto Area in the province. We have quite a large mandate. So within our region, we are focused on working directly to support the patient care for about 6.75 million Ontarians. And what you'll see there on that slide is just a sense of the volume and the different types of clinical stakeholder groups that we're working with. And as what you'll see on the bottom is that we are actually working with all the sectors at once. So I know there are programs that go out there and focus on maybe acute first or primary care first. we made the conscious decision that we'd like to go out and understand how this all fits together and get some lessons learned right up at the front working with all sectors. So just wanted to give you the context on our program and the scope and magnitude of what we're working on. The next slide is just a quick summary of where we are. So we're currently in the early adopter phase, or wave 1. We're working with about 20 organizations, and as you'll see on the slide, the targets of the data that we're looking to capture really focus on acute care and cCAC data at this point. Those are local data sources, and then we'll be looking at, we have connected in with a provincial data source to get our lab results. Our target in this first phase, it's quite ambitious, but we're looking at anticipating about 30,000 clinical end users to be rolled out to in the coming year. And I won't go into the details of the right-hand column, but we have engaged our Wave 2 sites. By the end of that, we'll be engaging an additional approximately 75 organizations, and you can see the targets there. You'll notice a difference in terms of the clinical end users. Our next wave will be much more focused on working with some of the smaller community organizations. So you'll see that reflected in terms of the user numbers, but what we're looking at there are the differences potentially in workflow and how we can look at addressing the gaps much more at the community level in the next phase so that we can look at accelerating access once we get beyond those 2 waves. So that's just an overview on where we are. I'm happy to say that we are in a limited production release right now, so clinicians are on the system and using it, and we are getting very good feedback. So I think we'll share some of that towards the end of this presentation. So in terms of the next piece, what we just wanted to highlight, some of you, many of you have done this kind of work before, and you might already be able to anticipate some of the challenges we faced. But I wanted to highlight for you what we kind of had in consideration. So you already heard about multi-sector. So a lot of different diverse perspectives, not just at the sector level, but at the individual level. So how do we engage enough clinicians to make sure that we're actually representing all the needs of our region was one of the pieces we were very conscious of at the beginning. The next is it's very much a multi-year program. So we're hitting about 20 organizations in the first one. We have about 750 in our region. So we're certainly just at the start. How do we actually maintain a group of clinicians so that we have consistency over a long term and that they continue to be engaged? So that was another challenge. Third, I would say our solution was still a concept. There are many programs that have the luxury of having something to be able to show that we've worked from. We had an idea, it was on paper, and we had to go out and sell it without very much meat on the bones at the beginning. And then last, what I'll highlight is that, like many programs of this size, we had a lot of shifting timelines. So how do we, Diana will go into this a little bit more, but how do we keep everyone up to date on what those changes are? What is the impact to credibility, and managing expectations about what we're delivering as a program? Along the way, as you would expect, we had a number of different delays, including quite what I would consider a significant service interruption at the start of our limited production release, which is not something we look forward to at the very beginning, but we have successfully come out of that, and I'm happy to say that our relationship with our clinical stakeholders is still very strong, and we continue to hear from them that they're just looking ahead to kind of the big picture and where we're going next with the program. So very quickly, just in terms of the change management approach, I don't think this will come as great news or surprise to everyone, but it's very much our approach to change management listed here. It is aligned with, obviously, Infoway's change management framework as well as ProSci. And along the way, what we've done is at each step, we've revised as we've gotten input from our stakeholder groups. We are going to focus today on the first 2 components. Engage, which is focused on governance and leadership, and then into the enlist and how we're getting people involved and keeping them up to date through the communications. So we'll focus on those 2, but very much our approach is integrated when it comes to the engagement, communications, adoption, and training activities. They pretty much happen all in parallel. It just depends on how we're using it at a certain point in time. I'll move on to the first one, which is our section on engage. I would say that for this part, and as Krista mentioned, it is very critical to the success of programs like this is to make sure that we have visibility for our key champions. In this case, it was a very conscious effort to make sure that clinicians were always first and foremost in our mind when we were making decisions. So what I hope you'll see when we were going through our presentation is that we very consciously, not only did we build in opportunities for visibility with our kind of clinical champions, but we also had to work on creating opportunities at the site level, as well as, engaging a variety of different leaders at different points in time to build and create those opportunities. So we'll try to highlight that throughout here. In terms of the engaging governance, the first point I'll have up here is that it's very critical to place clinicians in leadership roles. And what do we really mean by that? We've had a lot of feedback from clinicians saying, I get asked to be a part of a number of organizations and governing bodies. How do I know that this is really my input is going to be used and it will be meaningful? So we took that to heart, and I say at the beginning we were very deliberate in making sure that we knew exactly what decisions we wanted, what kind of areas did we want key input in, and that really helped to guide our plan. And even before we went out to engage our clinical working group members, we knew what those key points were. We, of course, refined it along the way, but very much so we identified right at the top where the influence was going to be. So when we did finally go out to engage clinicians, we started with our clinical co-chairs. And as you know, there were lots of different type of clinical stakeholders that we're working with. So our first decision was that we wanted co-chairs, and we wanted them to represent a wide range of the sectors. So in our case, we had an acute care representative as well as a primary care representative. And we were very clear to make sure that that group, those two clinicians, sat on our steering committee, and they had voting membership. So that really empowers them to be able to say to their colleagues that they then brought on to the clinical working group that you will have a say, and we're kind of 2 of our 20 members on the steering committee, and that we will be bringing your feedback right back to the table. So I think that was very, very helpful for us. I'm not going to go through all the points on here, but I want to highlight some of the things that were just unique for us and what we've heard back from our clinicians. So we had our 2 co-chairs. We also felt like we were missing the nursing representation. So our clinical advisor that we brought on for the program team represented the nursing perspective. So between the 3 of them, we had weekly meetings, and that really allowed us to keep up with the ongoing changes on a program of this nature, as we don't know everything going in. So on a weekly basis, we were able to get some very valuable clinical input, and that transparency and that level of involvement really allowed them to make sure that they knew they were a part of everything in every process. So I'm talking from procurement through to privacy policies, all the way into, what are our adoption targets and what does the rollout plan look like for the sites. They had input in all of that, and they were always providing the recommendation to our steering committee. So that was really critical. The other piece that I will highlight on here is that create and commit to guiding principles. So, most programs have this. We had our objectives at the beginning of the program, but what we did was we actually went to our clinical working group to ask them to create our initial set of guiding principles that everyone else then had feedback into. So it was clinicians who really delivered on these principles for us. And what I would say is you can see them on the slide there. They're not necessarily unique. You may have heard of many of them before. I think what was distinguishing for our members is that they were the ones to have the say that these 5 were the most important. And because they actually didn't change very significantly once we got input from steering committee, technical working group, privacy working group. So they were quite happy about that, and I think that was kind of our first step to delivering on our promise that their input would actually be used and we would commit to it. So these hold still true today, and we actually haven't changed them from the start of our program a couple of years ago. The last couple of points, just being transparent about our unknowns and limitations. So obviously we didn't have our system at the start, so we had to be very clear along the way of what we could do and what we couldn't do. And those weekly meetings really helped us actually, because we were able to walk our clinicians, or at least our advisors, through what was happening day to day and what some of the ongoing challenges were. And then the last piece is, I think many of us have heard from our clinicians, allocating funding is critical for the recognition and the value that clinicians provide to us. We know that we were quite fortunate, but we know that every project has its own limitations in terms of what you can actually provide in terms of supporting compensation or funding. We used a bit of a mix. So we did set aside a little bit of money where clinicians, where it wasn't their day-to-day role to be working on e-health initiatives. So, like a CMIO, a Chief Medical Information Officer, I would say, many of them their job responsibilities are to support e-health initiatives. So there wasn't funding provided for roles like that, but where we were taking time away from clinical care, there was compensation. We also used a mix of a bit of honorarium so that at our sites, we did provide some funding, but it wasn't time-based. And so far, at the beginning, I think we had a few comments around there could be more, but, I think everyone's been very supportive, and we also were able to secure some voluntary time for our usability testing. So, there are ways that you can work around it. I think it's more important that there is a recognition that it's the value of the time. So I'll move to the next one. So we started off with, the previous slide was about engage at a program leadership perspective. The next slide is really, this piece was much more about leadership at the local level. So not only did we want to make sure we had, input and content from across central Ontario, but we knew it was really important that we had, at an organizational level, that we were hearing what were kind of the, the major issues or complaints, that we had a venue and opportunity for that. So we did look at working through that with our site. So we had some very clear role descriptions from the very start in terms of engaging our sites, and hopefully it's clear enough on there. But we didn't start off with kind of qualifications. What we started off with was how, leadership roles and your ability to transform, and would you like to be a leader in improving care, rather than we would like 5 years of experience and we want your role to be such and such. We were really looking for the objectives and the impact of their role. So we participated in doing that, and then I would say the other part of it is, I'm just going to skip through and put all the tools up there. The other part is we were very engaged at the very beginning, so we were quite personal in terms of customizing our materials and outreach. And one of the kind of biggest pieces of feedback we received was that in our invitation letters to engage, we not only stressed the importance of the regional one voice that we were trying to create, but we also customized to highlight the specific value proposition for that individual and sector. And we did get a number of comments back saying how important that was for them, that we recognized it wasn't kind of a cookie-cutter approach, and that it was one of the first times they had received a letter where they were able to actually see their day-to-day work in a regional initiative. So, I think it was a very small move on our part, but it went a really long way. And we just continued with that as we went forward. So you'll see here really just more about customization, clinical kickoff. There's a sample of our overview presentation. We use clinician bulletins that Diana will probably reference later on. I'll just draw, as one of my final points, I'll just draw your attention to the bottom right corner, a clinician work plan timeline. So in terms of governance, I think it can be very difficult when you're engaging so many clinicians. We engaged about more than 200 individuals directly in input. Obviously, we can't have them throughout the whole program, but what we did do was identify certain areas where we needed certain numbers of people and for how long. And so when you're involved in those, it can be very difficult to understand, what your kind of small contribution is in the bigger scheme of things. So what you'll see on that one slide, and it's a very simple tool, I'm sure we've seen, program schedules like this before, but what that identified was every group, every level of clinical involvement we needed and how it fit into the big picture. So set up in a timeline, everyone was able to see, oh, I understand, like you need my time here for this, and it's dependent on this, and here's what it's going to lead to. We use this regularly at every level, and it really helped to make sure people were seeing themselves in the big picture, even though they couldn't commit to the whole time, or even though we weren't speaking to them, on a weekly basis. So those are just some of the highlights. We're happy to share tools as well throughout this process, and we can work with the team here at Infoway. So now that I've established, just a bit of the clinical leadership process and the tools that we use, I think it's a good segue to Diana, because she's going to share with you from a communications perspective the processes and the materials we used, and really what some of our results have been to date. Hand it over to you, Diana.
All right, thank you. So as Melissa said, we've engaged our clinical leadership. The question is now, how do we keep them engaged, and what is it that we have them do, and how do we communicate with them on a regular basis? And I'll just go back a little bit to Krista's definition of communications, which was the process of providing stakeholders with what they need to know to prompt appropriate responses and or actions. So based on that, we actually looked at communications as it's always done with a purpose. So we don't just communicate for the sake of communicating. We make sure that we are providing the right stakeholders with the right information at the right time, and that is a challenge, especially in a program like ours that is so deep in terms of the number of stakeholders that we are dealing with. But from a clinical perspective, we wanted to make sure that the messages that we were communicating were relevant to that group, and that they were consistent with what we were saying both internally and externally to our other stakeholders. So with our clinical leadership within the program, we also had clinical leadership within our organizations at the sites in the form of clinician champions. And the question was, how do we communicate with that group on a regular basis, and what do they need to know and what do they need to do? We'll start with the Communications Adoption and Training Toolkit. So we actually integrated our approach so that we talked a little bit about how we message information for the right group at the right time. Well, the toolkit was actually not designed for the clinicians, but we needed to establish a way that we would work with those clinicians on a regular basis. And with that, we had single points of contacts within each of our organizations. They are site project managers, and they are conduits into the organization and into our clinical group. And with that, the toolkit is actually designed for them with tools and templates that they can use on a regular basis. In there, the toolkit actually contained information related to communications. So specifically to communications, we created a template in terms of what does a communications plan look like. We provided some suggested tactics that they might use. We also helped them to help identify who their audiences were. So the clinicians were one key group, but they actually also work with other key groups within their own organization. So with that foundation, we also moved within that toolkit to talk about adoption. And when it came to adoption, we knew that as a program, we had some targets that we needed to meet. How did we translate those targets down to our sites to help us reach these targets? And it was very much, as Melissa said, leadership from within our clinical group, as well as support from our steering committee and our other governance bodies. So we weren't asking for anything that sites could not do, but what we asked was how can they help us achieve these numbers, and what is it that they need from us to help get to this goal. Change readiness assessments were one example of that. Again, this was within the Communications Adoption and Training Toolkit, and this was the adoption component. It was designed for the site project manager, and with that, the site PMs, they actually had tools as to how to speak to their clinician champions about getting the information that was needed. So the clinician champion knew what their role was. They knew that they were overseeing the clinical component of connecting GTA at their organization, but the day-to-day legwork was where we worked very closely with the site PMs to deliver that information. Change readiness assessment, we actually used the Canada Health Infoway change management framework as a guide to developing that particular tool. And within the toolkit, we actually referenced the change management framework. So there was a link directly to it, and we highlighted some of the key tools that sites could use. So we did Change Readiness 1, which was an initial assessment of who are the potential users, how many are they looking at, what kinds of information would they need. And we also talked a little bit about training. So we had an idea as to what training might be needed from feedback from our clinical working group, but now we were asking the sites specifically what they needed. We got some pretty good information at a high level, but we needed to drill down a little deeper, and so we did Change Readiness 2. And with Change Readiness 2, we also used the training needs analysis, and the two charts that are visible here on the screen are direct results of the the training needs analysis, where the sites identified the key tools that they needed to help train their users. So, and that was based on the readiness assessments that they had completed previously. So based on both Change Readiness 1 and 2, as well as the training needs analysis, we were able to adjust our adoption plan to make sure we were able to provide the sites and the clinicians with what they needed to move forward with that. So those are some of the key tools that the sites needed in terms of what they need to start thinking about in terms of reaching out to other clinicians in their organization, as well as understanding who the users were going to be that was supported by the clinician champions at each organization. Then we had the executive indicator report, and on the following slide, we'll go into it a little bit deeper. But now that we have the tools that the sites are using to help us reach these targets, we need to make sure that they stay on track. And one way we did that was incorporate adoption-specific targets that were within a larger executive indicator report. So keep in mind, Connecting GTA is a huge initiative for these organizations. There are a number of different components, privacy, security, technical. There's so many different components that the sites are actually working on. There are milestones along the way that they need to achieve, and they are all embedded within our executive indicator report. And specifically within that indicator report, we had some adoption-specific targets, and we'll get to that a little bit later in the next slide. And finally, clinicians wanted an opportunity to have a voice and to provide some feedback. So we actually had design sessions with our clinical solution team members who actually are also our clinician champions. And we don't have the time to go into that today. I believe that's a full session on its own. We're happy to come back and talk about it because it's we loved it, they loved it, and it's actually why we are where we are today, in that we have a solution that they did help design that they're now actually beginning to use. More to come on that, but if you're interested, we're happy to come and talk about that particular piece on its own because it was quite extensive and exhaustive. So then moving along, just back to the executive indicator report, we did have some very key specific adoption indicators that helped clinicians understand why they needed to be involved and that they were accountable for their involvement and their participation. I'm not going to read through them, but one of the key pieces was for each organization to identify a clinician champion. And when Melissa talked earlier about role descriptions, we were not vague with our role description. We were very specific about the level of clinician that we were looking for to participate. And as such, we requested that the clinician champion from each organization be a chief medical information officer or at least a chief. Someone in a decision-making capacity who could move things along and who also understood how their organization worked and functioned so that they can then share information with us so that we can support it as well. We also asked each organization to identify a clinical solution team member. In many cases, the clinician champions served that purpose. In the odd case, they delegated that responsibility. But those are the folks that actually sat and helped design the solution that they are now all using today. And then the change readiness assessments as well. We made sure that they were indicators that needed to be completed. So they weren't just tasks that they sat on the side of their desk that had no input and no feedback from. We actually used those tools, the information from those tools, to help guide our program. We took information from those assessments, we consolidated it, we shared it with our clinical leads, our clinical working group, as well as our steering committee, so that across the program, everyone understood what the organizations were telling us and how we were responding to what they were asking for. And so the minuscule picture on the bottom left is actually what the indicator report looks like. It is, just back to Melissa's point about transparency, it is a transparent tool in which every single organization can see how their colleagues and counterparts are doing on a deliverable by deliverable basis and a milestone by milestone basis as well. So we've got lots of greens, the occasional reds, yellows that are somewhere in the happy middle. So that was an important tool that we made sure the clinical voice was also a part of, but they actually understood that they had some accountability. And it was also a key element of communications for us because the executive indicator report itself was designed for the executive sponsor at the organization. And with it, the clinician champion is now forced to have conversations with their executive sponsor about how they are tracking across the board. Finally, one other tool that we introduced was the adoption scorecard. So this is still in refinement, but we needed a way to help the organizations monitor how they were progressing. And we created a tool that it tracks their training numbers. It identifies what potential adoption issues each organization might have. And it also tracks on a month-by-month basis once they go live, not at this time, but once they go live, how they are progressing with reaching their specific adoption targets. That then rolls up into a program-specific adoption scorecard that also feeds into the executive indicator report. So here we're able to track how the organizations are doing once they go live, and it's also a communication tool that our clinical advisor will be using to have conversations with the clinician champion. And of course, once the LPR kicked off, we had our clinical leads. The person in front is Dr. Peter Rosas, one of our clinical leads, and the person faded in the background is our other clinical lead, Dr. David Dane. They were the first users in the solution, and so this was our kickoff. And then the image below is our pilot site, St. Michael's Hospital, who went live with the limited production release back in July. So this was just when we actually kicked off true clinical engagement with clinicians actually using the solution. And of course, I would say that we're currently in the educate and exchange phase as the LPR kind of sits in there. And there's more to come with these two phases as we continue to roll them out. We're looking at an expanded clinical use phase as well as preparing for full go live. And of course, more to come. So now I will hand over to Anne to talk about stakeholder engagement.
Hello, it's Anne Baldwin. I'm just going to briefly introduce actually stakeholder engagement, and then I will be passing it over. But it is our next component in the change management framework, and it is the process by which perceptions, expectations, and issues of stakeholders are identified and managed. So key first, of course, is to try to focus on the individuals and groups who are impacted by the change. Unfortunately, the challenge is not so easy as appreciating that. Challenge is to determine who will be impacted and what would be the best level of engagement. So to illustrate stakeholder engagement, I'm going to pass it over to Carl Mallory. He is the project manager for the BC First Nations Panorama Implementation Project. And it's my pleasure to have Carl with us today so that he can walk you through their project's experience and the success they were able to have using a unique type of engagement. Carl, I will pass it to you.
Thank you very much, Anne. And thank you, everybody, for joining today. I'm happy to have you here to listen to our presentations. So I'm going to talk a little bit here about this rather large and complicated project that we're in the midst of. It is a very complex technical, political, and clinical environment within which we're working out here in BC. And there's lots and lots of history related to First Nations desires and access to use provincial information tools. With this project in trying to support First Nations to access and use provincial systems, there really weren't very many precedents, in fact, really none that we could find out to follow, and not a lot of policy to go on. So some of this was make it up as we go, so to speak. We also did encounter, and I don't think this comes as a surprise to many, that there were significant capacity gaps across the multitude of organizations, particularly the First Nations organizations that we were working with. And all told, hundreds of stakeholders that were necessary to identify, prioritize, and engage with. And actually, all of them turned out to be very important to the success of the project. So the other very critical success component here is that it became clear early on that there was required significant change at multiple levels within the organizations here, both within and across these organizations. So our goal overall was to integrate First Nations into the provincial public health program here in BC, and we wanted to try to promote that and advance that by supporting First Nations to access and use Panorama and see that as a catalyst for some transformative change in the environment. Two really key points I want to emphasize here before we get into the details of this presentation is that overall this project is not an IT project. Of course, there are components of IT that go along with the implementation of a e-health system, but really this is a business integration and a transformative change initiative. And the other key component is that here in BC, the adoption and use of Panorama, and I suspect this is the same across the country, is an optional program for First Nations. So it's less about supporting a change that is coming with one system being taken away perhaps and another being put in its place, and it's more about developing the necessary engagements, relationships, and value propositions to support good adoption here with First Nations. So if I talk about the summary of outcomes here that we've achieved so far, we did achieve successful adoption, and that started back in the fall of 2013, and that trailed BC's provincial adoption of Panorama by about 3 months, and that was a deliberate delay that we wanted to let the province system a little bit stabilized. So we have our first user was actually Shelley Clement. She was the community health nurse in Slam First Nation, and to our knowledge was the first on-reserve community health nurse to access and use a provincial instance of Panorama here in the country. We were very fortunate to receive a Canada Health Informatics Award back in June 2014 for our work to date on the project, and are still very happy that Canada Health Infoway wanted to nominate us for that. It was quite an interesting event. And we are continuing to deploy to BC First Nations health service organizations here across the province. So our user numbers are starting to grow, and as a result, so is the integration with the public health workflows. And really our success to date has come through a deliberate focus that was taken way back at the beginning of the project on people and relationships. Another component that's really important to emphasize before we talk specifically about engagement is the concept of governance and leadership. We follow a tripartite project model out here where we work with the federal government, the provincial government, and with First Nations, and have a joint decision-making process and model around key project direction and activities. We also are very fortunate to have incredible leadership and support from the most senior public health professionals here in the province, both in First Nations organizations and in provincial organizations and within the regional health authorities, so that really helps. We also have a remarkable advisory group that is made up primarily of folks on the ground who are really at the end going to be impacted by this initiative. So we have several community health and public health nurses, as well as health directors from a number of First Nations health service organizations and representatives from the business and program and policy departments in the regional health authorities, Ministry of Health, First Nations Inuit Health Branch of Health Canada, First Nations Health Authority, and the BC Centre for Disease Control. So that advisory group has definitely provided us with some frank and practical advice, and I love working with nurses because they tend to be very clear and direct in their advice, which is lovely. They told us to do things right and not just try to do things fast, and that has really helped us over time. They've also told us to be very flexible and practical and design a model that works for everybody and not just go for the large organizations that are urban-based, but make sure that all First Nations have an opportunity to access and benefit from this system. They wanted us to engage with all partners and make sure that everyone was clear on what needed to happen and that change was going to be required of everybody, not just the nurses in the First Nations organizations. They also wanted us to gain agreement early on from our partners and, importantly, from our funders, that there was going to be a large degree of engagement required here and that was going to be necessary throughout the duration of the project if it were going to be successful. They also wanted us to keep it clinical and stay out of politics. They warned us that if we were to venture too deeply into politics here, we'd probably never find our way out, and that staying at a clinical level would ultimately serve us well in the end. which it certainly has to date. They also told us to prioritize our engagement effort to First Nations and to ensure that we understood what's happening on the ground, what the challenges are, what the requirements are, and what the hopes and desires are of the community health nurses and the health directors in the large number of First Nations organizations here in the province, and make an effort to understand these stakeholders' perspectives, their challenges, their practical realities, and don't just assume that we know from sitting in Victoria, for instance, what's going to actually work at a practical level in one or more of these organizations. They told us to get out there, talk to folks, meet with the people essentially, and develop some street credibility, and that would help us. So we wanted to take that advice. One of our practical challenges right away was that the distribution of First Nations organizations and First Nations bands here in BC is broad, and there's a high number of them. There's 203 First Nations here in the province, and there's approximately 100 organizations that provide service to one or more of these First Nations. So we took their advice. We traveled by road. We traveled by small plane, not so much by boat, but I always like that picture of the boat up in the Gitsan area. And we visited many, many sites. We drove on logging roads and experienced what it was like when trucks break down halfway through a 6-hour voyage on a logging road in the middle of winter. We also took many small planes and continue to in the stormy fall and winter months on the north coast of BC, and understood what the effects of that can translate to. It can be a little bit dodgy sometimes, but sometimes it's the only way to get into some of these very, very beautiful locations, but also very remote locations. And it gives us a good appreciation of how challenging it can be to, first of all, get out of these communities to access health services, but also how challenging it can be for the nurses and the health directors to even come out to go to meetings, for instance. So in most times, we try to go to them because we know that asking a nurse to come out of one of these communities can be 3 days of the community not having access to a nurse, for instance. So everywhere we went, we saw beautiful locations. We saw small places. We saw isolated places. We saw urban places. Always a health center was our focus, and to try and understand how things worked in that health center and how the partnerships worked with the provincial partners. We went to some very rural and remote health centers. We also went to some urban health centers. We went to some larger health centers, and we went to some smaller health centers. Everywhere we went, we were met by very appreciative and very eager nurses and health directors who were anxious to take part in this initiative, anxious to start addressing some of the challenges they have in having access to accurate and complete records about their clients so that they can have good information, complete information in their hands when making decisions about their care, and so they can collaborate and communicate within the circle of care for their clients when these clients are moving across organizations. So no shortage of smiling health directors and nurses wanting to take part in this initiative. And so that led us then to a bit of a dilemma, but a good dilemma, and that was how do we actually select the organizations to start working with, the organizations that are going to help us design a methodology that's actually going to work so that we're not going out, as they say, to the community with baked cake, but we're asking people to contribute the ingredients to something that we're making together. So being conscious of not wanting to leave anyone behind and being fair to make this opportunity open to everybody, we sent out what we call our request for expression of interest. And that was sent out to all the health centers, all the health organizations that we could get email addresses for, or mailing addresses for, or fax numbers for. And it basically asked, who wants to be part of this? Who wants to go first? Who wants to help us design the methodology and pilot this methodology to see if it actually works before we start rolling it out to everybody else? Ideally, we were hoping for maybe one organization from each of the 5 regional health authorities would make a nice small pilot study. But what we ended up finding out was that we had an overwhelmingly positive response to our request. We got requests back from about half of the organizations here in the province, all wanting to go first. So this was a good problem to have again. What it turned into, though, is we really didn't have any resistance to adoption, so we didn't have to put a whole lot of effort into trying to overcome resistance to adoption. However, what we did find in our travels and in our visits and in our really open discussions with these organizations was that there are a number of challenges that we're going to have to deal with if we're going to make Panorama access and use a reality in these organizations. And these challenges are things like network connectivity, for instance. And I'm not necessarily meaning internet connectivity here. I'm meaning access to the networks where Panorama resides, the secure provincial health networks, for instance. Privacy and security, huge number of requirements at the ministry and the provincial level around privacy and security. And supporting these organizations to comply with these and to meet these requirements is a challenge and continues to be. Data governance, ensuring that First Nations health information governance is effectively integrated into the provincial model. Workflow integration, training and support, and capacity. Huge capacity gaps in some of these organizations, and frankly, capacity gaps in the provincial organizations too, and many others. So our challenge then was to incorporate these perspectives into a meaningful implementation model where we can provide practical solutions to these numerous gaps and barriers, many of which were not specific to Panorama, but were systemic. And is flexible, so we can accommodate all these organizations, be them big or small, urban or remote, and that there's a strong value proposition, so that when we're asking nurses and health directors to spend time with us, their scarce time that they maybe could be putting into actually delivering services, that there's something at the end of this for them that is perhaps broader and bigger than just access to Panorama. So thus was born the FNPIP implementation toolkit. And what this toolkit tried to do is integrate this philosophy that we learned was important about this continuous improvement, value propositions to everybody, doing things right instead of fast, having a strong foundation of relationships where it's safe to experiment, there's no precedence or policy to guide us, synthesizing First Nations requirements and principles with those at the provincial level, creating a methodology of project management that is not so much IT project methodology, but instead is more receptive or more targeted towards these environments, and then a suite of tools and templates that can support organizations to move through this without having to recreate the wheel every time. What this toolkit supports then is the implementation of a foundation within these organizations upon which they can access and use Panorama. But the value proposition we tried to create is that wherever possible, make this non-specific to Panorama so that it can be reused and extended through time. And so how that starts to look when we start thinking about the organizations that we are deploying to is that through the toolkit methodology, we systematically put in place the building blocks of this foundation: network connectivity, compliance with the eHealth conformance standards for privacy and security, integration of the requirements, legislative authorities, privacy and security frameworks, so forth and so on. And what this amounts to is a reusable First Nations Health Service Organization eHealth Foundation. So first and foremost, this supports these organizations to access and use Panorama. And to date, we have 7 organizations. Actually, as of tomorrow, will probably be 8. That'll probably go up to about 30 users by tomorrow, 38 First Nations, approximately 20,000 hours of clients. And then we have many more First Nations organizations in various stages of the process. But by extending the value proposition here, we realize that this foundation can also be used to support accreditation. And we have several organizations that have used components of this already to achieve accreditation, and several more that are working through that process. Similarly with telehealth, many of these foundation building blocks are supportive of these organizations accessing telehealth services. Community EMR, several organizations here, many of them in fact are either using community EMR like the Mestima product or are moving towards it. And partnerships. When everyone is aligned with the provincial standards, speaking the same language, it makes partnerships easier to initiate and also maintain through time. So throughout all of this process, though, none of this would have happened if we hadn't have had the ability, the coverage, and the good advice to actually conduct a stakeholder engagement process in the right way that actually worked for the environment. And part of what we needed to do is understand what that meant and be humble about that and be willing to take the advice of those that were willing to guide us, and then to actually go forward and have the time to actually do it properly. And we continue to do that to this day with the organizations that are still interested in accessing and using Panorama. And with that, I will leave it there.
Thank you very much, Carl. We have a few minutes for questions, so we'll open it up for questions. If you have any questions in the Q&A section, please do send those in to us. We had one question come through asking where on the Infoway site to find our information. If you go to our Infoway corporate site, you will see along the top a toolbar that says Communities. If you click on that, you will see the Pan-Canadian Change Management Framework, Change Management Network. If you click on that, then you'll get to our Pan-Canadian Change Management page where you'll see our toolbox, our toolkit, our framework, and lots of information. While we're waiting for questions to come through, I will ask a question of, first of all, of Diana. Diana, you mentioned that this is a long-term project. I heard a discussion of 2 to 5 years, but it's a large project, cGTA. How do you manage communicating delays to your stakeholders while trying to maintain forward momentum?
So one of our guiding principles that we had established early on with our clinical working group members and our governance structure basically is transparency. We kind of take the approach that we're all in this together, and so when we do have delays, we have a process in place by which it goes through a certain path. That path includes our clinical leads, our clinical working group members, and the decision lies with our steering committee. And from there, we send a single message, but to various audiences and somewhat tailored to them. But whether it's executive sponsors, clinician champions, various folks within the organizations, we just make sure that the message is consistent and timely as well. So we do have a path, but transparency is the key.
Thank you very much. We have a question from one of our participants. How did connecting GTA deal with local needs and requests for changes to regional system design?
I can take that one. So I think this might be a bit of a precursor to us coming back, but I think what's really key is that we engage clinicians at very different levels. And one of you would have seen a diagram in Diana's slide. We actually brought in from every participating organization one representative to help us design the solution. So when we got into the room together, everyone was able to hear from one another, what they really needed, how they would use the system. I will say that it was unexpected for us, but nobody really agreed on the same thing. But what they did agree to is that they would allow enough flexibility in the design of the solution to meet everyone's needs, and we would focus on customization, allowing for customization and flexibility. So everyone had a chance to provide input on local needs, but I think that was one of the strengths of the approach we took, is that everyone got to hear where each other was coming from, and so they could agree in some cases, yes, I'm willing to do that for you because there's really little impact for me, or they decided to allow for enough flexibility in the design of it that somebody could customize for their local workflow or whatever it is within the system itself.
Thanks very much. We're just about 2 minutes from the top of the hour. As I mentioned before, we have information available on the framework on our Infoway website, as well as toolkits. Both Carl and Melissa and Diana mentioned that they have used tools that they will be able to share with us, so we will be getting those shortly and putting them on our website, so you'll have access to those. Also, on behalf of the Pan-Canadian Change Management Network, I'd like to thank our presenters, Melissa, Diana, and Carl, for sharing their change management success stories with us. If you have change success stories you'd like to share, we'd love to hear from you, so please do contact us at the email that's on the screen. Thank you for attending our webinar today, and have a good rest of the day.